The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. It's all fun and games until someone gets sued, am I right? Okay, on with the show. Hey, welcome back to Knowledgeable Provider. I'm your host, Jody Marks. Got a very cool interview to share with you today with Miss Alaina Peterson. Alaina's a nursing instructor at Calhoun Community College, whom I've had the pleasure of working with for the past year, going into our second year working together with the Bridge program. Of course, she's the real teacher. I'm just the big helper. But she's made a big impact on our program. She's made some changes that I think are going to really be helpful for the program and lead to a lot of success for our students down the road. So I just wanted to talk to her about her general philosophy of education and some of the specific changes that she's implemented and things that she's thinking about for the future. It's a very cool conversation. If you're at all interested in medical education of any type, I think you'll probably be able to tell from listening to her what a soldier she is. We had planned to do this interview, and when the time came, she was in the middle of a sort of a family crisis. And I said, of course we can, do this another time. We can reschedule this. She was like, oh no, we're doing it. So she just pulled over on the side of the interstate somewhere and did the interview by phone. So the sound quality may not be as great as if she had been in a home situation, but I think it came out fine, and I doubly appreciate her time because she certainly didn't have to do that. So there you go. I hope you enjoy our conversation. Alaina Peterson, welcome to Knowledgeable Provider. Thanks so much for doing this. I really appreciate it.
Of course, I'm glad to be here.
Fantastic. You want to introduce yourself and give your background and bio and that sort of thing?
I'm Alaina Peterson, and I am nursing faculty at Calhoun Community College. I actually went to Calhoun Community College straight out of high school. I am one of those with an August birthday, and I graduated high school at 17, went straight into their LPN program, and actually had my LPN license a few days before my 19th birthday.
Wow.
From then, I got my BSN from JSU. I got my master's in nursing education from UNA, and I'm currently in my doctorate program at UNA, and I'll graduate next summer, the summer of 2026. I start my big practicum project, research project in the summer. So that'll be a year of research.
Do you want to talk about what your project's going to be?
Sure, it is going to be, as long as they approve it, because, have to go through the IRB board, and I'm going to be doing research on actual students, but it's going to be the use of escape room technology in simulation to increase clinical judgment.
Escape room technology. Can you explain that?
So simulation, students have simulation, at least 2 simulation scenarios each semester, and it's where they go in and they take care of either a high fidelity mannequin where we can set what the lung sounds are, talk through the mannequin, all that, or have an SP, so a standardized patient, a real person playing a patient, including escape room technology would be they're trying to take care of the patient, but also solve puzzles while doing that. So a series of lock boxes and riddles, but it's all medical related.
See, this is why I wanted to talk to you. This is amazing.
Yeah, I think it's going to be a lot of fun.
It sounds fun. I want to do it. I don't know if I'll be able to escape, but I want to do it.
So, like, an idea would be patients on heparin, and the 3-digit code is their PTT results.
I love that so much.
And there's some ideas out there as far as like already built scenarios. So I would probably take the easy route by taking a scenario that's already written and then fitting it to my needs. It's newer, so I'm having a harder time writing my literature reviews about escape room technology in simulation, but I think it's something that does need to be researched.
this kind of thing that we're talking about right now, which we didn't even plan to talk about, is exactly why I want to talk to you. You're such an innovator. You're a change agent. When did you transition from bedside to education?
I did that during COVID. So when I got my LPN license, my first job was in corrections, which is crazy for me to be not even at a legal age of drinking, and I was taking care of inmates. That's also how I happened to meet my wife, and I joke that we met in jail, but literally we did. She was the arresting officer, and she would bring me inmates, and I would have to book them in to our system as far as like a medical triage. At the time, Calhoun had a bridge program, well, like a separate LPN program. Of course, we still have a bridge program because that's what we do. That is what we are over. But I applied to the bridge program and was in that next cohort. When I got my RN, I started in the ER and stayed in the ER for a while. I did some travel nursing. I didn't go anywhere cool, just Alabama and Tennessee. And then during COVID, I did COVID ICU, and I swear that made me learn so much as a nurse and it pushed me to my limits, and I loved it, honestly. It was pretty traumatic, have the amount of people that died under our care because that's when they were just throwing everything in the kitchen sink at these patients, and then they just went into mods and there was no coming back. After their lungs failed and they ended up on the vent, it was, okay, what's next? Is it their liver? Is it their kidneys? Usually it was the kidneys to go next. And then, of course, with COVID, they would clot for no reason. So they would throw PEs or DVTs, and it was just no going back from that. But that is not why I stepped away from bedside nursing. The reason I did was because I was still PRN at a ER, and when I would come home from dealing with all the COVID death, I would step foot into the ER and I'd get cussed at for not giving pain medicines quick enough, or they're hungry and want a turkey sandwich. And my boss at the time was not very supportive and everybody was burned out. And I was like, I've got to do something different.
Yeah.
So I started with Calhoun the spring of 2019, so pre COVID, part time as an instructor. So doing clinicals in the hospital with students. I decided to do that on a whim, I guess because I was bored, but also because I really enjoyed mentoring new employees and having students because, students come onto your unit and everybody's like, please don't stick me with a student. I was always the one like, hey, give me a student. I love teaching and always felt like I had good feedback from them. And then when I became part time with Calhoun, it was really validating to have students have that light bulb moment with me where they're like, oh my gosh, all of this makes sense. Even my teachers that are real teachers, nursing teachers, could not explain it to me the way that you did. And so when I had that burnout time, I was like, maybe it's time to move to education full time. So that's when, in the middle of all the COVID mess, I decided to go back for my master's degree.
That's quite a backstory. You've had a lot of experience in a short time.
Yeah, that was a lot.
Yeah, it really was. My impression of you is that you are very enthusiastic about doing some different stuff and pushing for change. And I really admire that. I think you see that just in new instructors in general, but I think there's just something different. There's something more about you that I think you can actually do it. I think you can actually make the changes that you talk about making. And I guess I want to just dive a little more into that about your attitude and your method and kind of the specific things that you want to see implemented. And I do want to say I don't want to sound like I'm saying anything bad about Calhoun or about any of the other instructors. I also went to Calhoun as a student. I got a great education there. I had great instructors, and then I actually started working there about the same time you did. And I've had a wonderful experience with all the other instructors working with them. Like, it's a great program. We have great faculty, great administration. I don't want it to come across like I'm saying anything disparaging about anyone else.
Oh, and I completely agree too.
Yeah, yeah, yeah. But that being said, like, I went through the program in 2012. I came back in 18 or 19, and it's pretty much the same stuff. Like the way I was taught as a student is the way I'm teaching students as an instructor. I don't do clinicals, I only do classroom stuff. So, we stand up there and lecture and the students take notes or do whatever they do and they take an exam and then we do the next section. Like it's just kind of always been that way. And you're the first person I've heard really come along and say, "Hey, why don't we do something different because this stuff doesn't work?" That's my point of view on all this. So, do you want to just talk about your point of view on the whole situation?
I think it really came from seeing some instructors not be as effective in my personal nursing education and wanting to do right by my students. And again, there's nobody that I feel like is being malicious, but I think there's a better way of doing things. And then I also think a lot of it came from my master's education at UNA. For those of you that don't know, you can get a master's degree in nursing with different tracks. So, Jody, you went the nurse practitioner route. I did not go that route because I knew that I didn't want to do that. So, with the master's degree, we all start out with the same core courses. So, the advanced pharmacology, advanced pathophysiology, advanced health assessment. And then from there, you kind of branch out, whether you're going a research route, leadership. There's lots of different routes, but I chose nursing education. And so from there on out, it was all about okay, what works, what doesn't, what are innovative nursing technologies that you can use, and learning the science of learning and how the brain works, understanding the research of what has worked in the past and what hasn't worked. So just knowing that and having that focus is what has brought me into that mindset as far as education goes.
How has it been trying to push for different things and bring in new ideas? Have the students and the faculty and administration been pretty open to that? Have you faced a lot of challenges trying to do new different things?
Yes and no. I would say that our department chair is great about giving us autonomy in the classroom, but also having us be mindful of our outcomes. That, yes, you can teach how you want, but also you're responsible for how many students fail or how many students pass NCLEX. So I take that to heart. I know that not all the students are going to like me or love me or think that I'm the best teacher ever. But what I care about is, do you know your stuff? Can you be a safe nurse? In navigating that and figuring out what is the best way to teach the students has been a journey. My first set of students, God bless them. I mean, it takes time, just like with everything else. I didn't start out being a fantastic teacher, and I'm nowhere near that, but that first cohort, of course, it probably didn't go as well, and I could tell that by my reviews. So, we get evaluations every semester, anonymous from the students, and they will tell you how bad you are. And you'll read those and go question your life. And then I picked myself back up and realized, okay, some of these things worked, some of them didn't. Let's go from there. I think a lot of it had to do with they are very used to being fed information. And then they're like, okay, well, why didn't I do well on the test? Because if they're fed the information, that's straight memorization. And we're trying to get them to where they can critically think. So if we go back to Bloom's taxonomy, the bottom of the pyramid is remembering understanding. We want to get them higher. We want to get them to analyzing information and being able to apply that information. I think the culture is definitely changing at Calhoun, where before it was straight lecture, you get your PowerPoint, you write your notes, and we test you on that. I think the change really happened when we brought in Nurse Think, and I think we're going to talk about that a little bit later. There's still some resistance, and there's some people that are just going to do what they do no matter what. But I think things are starting to change for the positive.
I always hear myself saying, I'm not a real teacher. You kind of get onto me, push back at me for that. But this is kind of what I mean. Like I don't have a degree in education. I haven't studied education theory. I just, I'm just kind of doing what I know to do. And I can tell you pretty objectively that lecture and you regurgitate it back to me just doesn't work that well for most people.
Mm-mm.
I think as a student, as a learner, I am somebody who that works really well for. Like I can listen to stuff and get it and spit it back out on a test, and I'm really good at that. So as an instructor, it doesn't always make sense to me why the students are not getting it.
Mm-hmm.
I am the prime candidate of like, I need to do something different. I need to find a different method.
You've been in those test reviews with me. And I'm like, I told them this. I told them this. It was on slide number 6.
Uh huh.
Like, this was just literally straight memorization. But did it stick? No. And there's a lot of, I could go on and on about the research studies about active learning strategies versus just traditional lecture and the results from that. I've researched it not only just in the nursing realm, but primary education, secondary education, other fields, engineering. And as far as immediate knowledge retention, the students can listen to a lecture in one group, and then in the other group, do an active learning strategy, and then they do a post test. And the results are very similar from both teaching strategies. But the knowledge retention, say a couple days later or a couple weeks later, is significant for the active learning strategies. The students that did the active learning strategies are able to pull that information and apply it at a later date. Those that had strictly PowerPoint do significantly worse.
Do you want to elaborate on what you mean by active learning strategies?
Active learning strategies can be anything from games to case studies to anything that gets the student participating in their education versus sitting and listening to me talk for an hour and taking notes. That looks different for everyone, and it looks different for me based on the content because not every strategy works for every disease process or concept or exemplar.
You want to talk about some specific activities and active learning strategies that you have implemented, either successfully or unsuccessfully?
I think when I have been unsuccessful, it's because either I didn't sell it well enough or I didn't have clear learning objectives. I'm finding that if I have clear learning objectives that for the students, they can see why they're doing it and what they're supposed to get out of it. If you're a little aimless with it, they're just like, why am I doing this? This is stupid. Why am I having to put any kind of work? Now, as far as specific stuff that I have done, I most recently tried for the students to make an unfolding case study based on a medication of their choice, which I recommended one of the medications that they did poorly on a pharmacology exam, and gave them a template and guidelines on how to make an unfolding case study. So that forced the student to go and look up this medication, look up side effects, and if they were making up this patient, well, what would go wrong with this medicine if they gave it incorrectly or gave too much or they gave the medication and a side effect happened? What would the nursing interventions be? And that's all the things that we want them to know about a medication. How do I give it? How do I give it safely? What things am I watching for?
I think I was there when they presented those case studies, and I thought they did a really nice job with it. And that sounds way more exciting than filling out a drug card, which is essentially the same thing. But I can see where they would definitely retain that more than transferring things from the drug book onto a sheet of paper.
Yes. I've also done just regular unfolding case studies. I've done one specifically on cirrhosis because that seems to be a weak point as far as the signs and symptoms of cirrhosis. And yeah, I can memorize that somebody's going to have ascites, but unless you understand the lab values and what is happening in the liver, what is going wrong, then it's doesn't really do you any good going forward on how to treat that patient. So I find that cirrhosis case study really useful because it helps them put those signs and symptoms and treatments into perspective. Another one I have done is an IV case study, and this is for our second semester nursing students during their IV skills checkoff. So, IV skills, they check off on initiating an IV, giving an IV push, an IV piggyback, IV fluids, and then discontinuing that IV. We have a rubric, of course, because a rubric helps us be fair to the students by telling them exactly what we expect from them and to be fair on our grading scale as well. But for the IV push, I felt like it was a lot of, I would look up, why am I giving this medication? I would look up side effects. It was a lot of, I would do this, I would do that.
Right.
So what I did was I took a case study and put it into DocuCare. DocuCare is our platform that we use through Lippincott that simulates the electronic medical record. So I put this patient in there. The patient has congestive heart failure. They're supposed to be giving Lasix to him. And the case study is, what are the disease processes related to this medication? Or why is this patient getting this medication? What lab values are you going to look at for this patient before giving the medication? Write down those lab values. What vital signs are you going to look at? How are you going to prepare this medication? Things like that. So they actually did really well, and we've seen a decrease in failure rates. And I believe it's because they have something to apply it to real world instead of, I would do this, I would do that, but actually doing.
I've seen that over and over and over again just in the lab simulation stuff that I've been involved in, because in the past we would do the lab stuff as we went along in connection with the lectures we were doing. And, when it's whatever, 8 o'clock at night and you've got 50 students to check off on something, like, just say what you're going to do and go, like, we got to get through this and go home. That's,
Yes.
that's more the attitude that everyone else has. So yeah, I can see where that would be way more helpful.
Just always taking it back to a patient because that's what they're going to be doing. Make it as applicable as possible. Always take it back to a patient.
You want to talk about the Nurse Think system? I think, was this our first year using that this past year?
Yes, so it was introduced in August of 2023. So we just finished a year of Nurse Think. Nurse Think is a fairly new product. So I know a lot of my associates or coworkers have felt that we're kind of like guinea pigs. I mean, I can see that, but I also can see the value in it, that it is a tool that we can use. So, their main product is their book bundle, which is the conceptual clinical cases. It presents these client cases or patient cases. I'm used to saying patient, but NCLEX uses client, so that's what we have to go to. But these client cases in the next gen style of NCLEX. So in 2019, NCLEX, which is the exam that the students take to receive their license, decided that they were going to introduce this next generation style of questions. So, along with having multiple choice, normal questions, they also have a set of case studies. They're giving a client part of their medical record. So that can include labs, orders, nurses' notes, and then they're given a series of 6 questions that take them through the nursing process. And that is what the next gen style is. So, what Nurse Think has done with their conceptual clinical case book is it's mimicking that. It takes you through a case and then through the nursing process in each case, getting them ready for not only NCLEX, but for real world. Their second book is the RN Conceptual Review Guide. And I say it's like the down and dirty of a lot of diseases. Disease processes or exemplars is what we say in our program. So it'll give you 2 pages on diabetes. Now, it's the very quick, very pointed version of what you need to know. And so it's a good study guide for those that are at the end of the program getting ready to take NCLEX and to review the most important information. Because I'm sure somebody probably has written an entire 500-page plus book on diabetes itself, but it just kind of consolidates all that information for them. The third product is the Nurse Think Notebook, and how they say it, it's note taking for every class, clinical, and lab. And it again takes them back to the nursing process as far as analyzing cues. What were your top three cues for this disease or this client? What are your top three nursing priorities, top three labs, and so on and so forth. Also, with the Nurse Think stuff, they have clinical judgment exams, which is a standardized exam, and it gives them a report on their weak areas. And then they do a remediation process to improve those weak areas. So I see the big picture, how it is beneficial. I think a lot of people are getting caught up on the little stuff that they don't like, and that's why they hate the product.
When you say people who hate it, do you mean other instructors or students?
Both.
Okay.
I think, well, if the instructor doesn't value it, the student's not going to value it. I think that goes for anything. That if the instructor is complaining about the product, then of course the student's like, okay, why are we doing this?
Yeah, remind me to ask you about care plans later.
Oh, okay. As far as like the Nurse Think curriculum and methods, I don't think it should be like 100% introduced to fundamental students, because fundamental students just need to know the fundamentals. And their products are more focused on clinical judgment, which I believe starts to be introduced more in second semester. And it can be overwhelming for fundamental students.
Yeah, I can see that.
I just think there needs to be program buy-in. Everybody needs to either get with it or we get rid of it. I mean, I know that's not going to happen, but I'm kind of in the middle. Like I see the benefit of it. I do have some doubts or little concerns, but they're like minor things that I think will get worked out.
I love just the idea of you don't have to know a whole chapter's worth of pathophysiology about, you mentioned diabetes. Like, as a nurse, if you pretty much get the basic gist of it, that's kind of, I mean, that's really all you need. Like, why do we have to spend so much time going over all this crap that you're never going to really use other than to take a test?
Yes, I agree.
My podcast episode that just came out is about diabetes, and I use the ADA Standards of Care guideline or whatever. That thing's like 330 pages long,
Oh,
and it
geez.
pretty much boils down to just the basic stuff that we all know about diabetes. But yeah, my experience with this Nurse Think curriculum has been really good, and I hope we go more toward that and not away from it.
And I think we can, since we're a smaller group in the bridge program, I think we can accomplish that and maybe be a success story on how we really integrated it and had good outcomes.
Yeah, for sure, because the students we work with, of course, already have a ton of clinical experience, so it seems like it would be right up their alley.
Yeah, I think so too.
A lot of them are older than I am. You know, people who have been working as LPNs or paramedics for a long time, have been out of school for a long time, and I feel like that's kind of the group that is going to push back and be like, "No, I need a paper copy of a textbook and 20 different colors of highlighter, and I can't do all this technology stuff." What would you say to that type of student or the student that has that approach?
That it has a lot to do with mindset, and I want to change that mindset instead of I can't do that. Well, you can't do that yet. Nursing is all about learning new things. It's goes back to evidence-based practice. Our practice changes, and so we have to be lifelong learners. And then there's a good bit of technology involved in the Nurse Think products, but also there's a lot of technology you have to learn with nursing in general. So I think it's just going back to soft skills as far as critical thinking, teamwork and collaboration, all of those things.
If you had unlimited authority and budget and like just you snapped your fingers and whatever you said goes, what would our program look like in 5 years? Any other specific things that you have on your mind?
I would probably integrate more technology as far as like smart boards in the classroom. There's virtual technology, virtual reality technology out there. Definitely include that. But as far as program change, I want to address that generational divide. I want to move past that the struggle is a necessity I think a lot of people are like, well, I had to do X, Y, and Z. So that means that these students have to do X, Y, and Z. But I think there has to be a balance. I'm all for having a struggle moment and not giving the students everything at the snap of their fingers, but also giving them all the tools needed to be successful. And then I'm not down in Calhoun or any specific instructor, but I think kindness goes a long way in meeting students where they're at, especially our students. They're non traditional. They're older, some of them are. A lot of them have families, husbands, children, and sometimes we have to do a little magic or just listening and understanding the problems that they have.
I'm always overwhelmed by some of the things that our students face. You have this person going through school that, oh, also is a single parent, or they're dealing with one of their parents that has dementia, or their husband just died, or wife just died. There are always these unbelievable stories of like, how are you even functioning right now? Like, I'd be in a fetal position, under a desk somewhere.
Oh, yeah, for sure.
I never had to deal with anything like that as a student, and it was hard enough.
Yeah, and I go back to when I was in school, I was still living under my parents' roof because I was very young and I had very minimal responsibilities. I can't even imagine some of my students having kids and doing nursing school or having aging parents or this, that, and the other.
Any tips about dealing with students in general? I find myself really struggling to know what to say when a student comes to me for help.
I have found that having the student assess themselves has helped a lot. A lot of times they want to come to you because they're at their wits' end and they're just like, tell me what I need to do. And it's not one size fits all. So that's why you have to assess what their learning needs are. One of our instructors, Gina Briscoe, is really big on student advisement and success, so much so that she has built modules into everybody's courses with forms for the students to fill out. If you make less than a 75, we highly recommend, I mean, we can't force anybody to do anything, but we highly recommend filling out these forms, and it asks questions about, are you the sole provider for your family? So it goes over work life balance stuff, study habits, and then you tally it up and it tells you what their weak areas are. And then it also has resources in this module on, if you're a really bad test taker, here are some things that you can try. Or if you have high anxiety, of course, we always, for things like that, we're like, hey, maybe you should see a professional. But there's other things that we can point them to. I have found just trying to make a connection with the students, and I'm still not the best at this, but learning names early on, trying to get to know them, where they work, do they have kids, what are their interests? And I have found that students will come and ask me things and divulge things if I'm more willing to meet them where they're at and get to know them.
How do you think we could do a better job of responding to the students' needs as far as we've already talked about some of the specific examples of extraneous circumstances, but things like language barrier, what do you think we could implement to kind of help our students that have other challenges like that?
I think it all goes back to just being very individualized and getting to know them. You don't know that they're having a problem unless you are able to recognize that and intervene. And I know a lot of people go back to, well, they're adults, they'll ask for help if they need it. Yeah, but you can't have that kind of perspective. You have to be willing to kind of seek them out sometimes. And as far as English as second language, I a lot of times defer to the ADA office. They deal with accommodations and things like that. So there are certain things that we can do as far as testing. For studying, I recommend in their textbook online, they have the platform where it can read the textbook to them. And I have found that is helpful for them. So there's a few tips and tricks, but again, it's all very individualized. What one ESL student needs, the next might not need.
Probably the most disappointing thing I've ever seen as an instructor, was a student that was struggling with the tests, and she told us that it was because she was having trouble understanding the tests because they were in English. That was not her first language. And when she told us that, I thought, "Oh, fantastic! There's got to be some easy way around that." And like nobody cared. Nobody did anything. Everything I tried to bring up, it was just like, "Nope, we can't do that. Nope, can't do that. Nope, nope, nope." And it was just that was pitiful to me. 'Cause that shouldn't really be a barrier to getting an education.
That's exactly right. I attended the NLN conference, which is the National League for Nursing, this past October, actually. And I attended a session on accommodating students and like, don't put up more barriers for them. Try to be more inclusive to everybody. The goal is to get them to NCLEX. And one thing that really stuck with me, especially with like physical disabilities, they can pass the NCLEX. And if they can't get a job at bedside because of whatever physical disability, there are other things that they can do as a nurse. So why limit them in nursing school? So I'm not saying just like roll out the red carpet and just let anybody in and through nursing school, but why can't we be as accommodating as possible?
And I should say with that particular situation, that student did fail out of the program. She came back the next year and rocked it, like, was one of the top students through the whole thing. And I got the chance to ask her, like, "What changed? What was different?" And she said, "Oh, I just wasn't sleeping last semester." So, I should say in that particular scenario, maybe that wasn't the right reason that she was focusing on, that she was not doing well. But still. What do you think we could do to do a better job of preparing our students to take care of a more diverse patient population? I always find myself coming back to these biases that are built into healthcare research and evidence. I guess a classic example is that we learn what rashes and stuff look like on white skin, but we really struggle to identify those things on brown and black skin. We saw the situation recently with the kidney function guidelines. We realized that they were skewed in favor of white versus black patients. We had to go back and try to fix that. As far as just nursing education, how could we do better with that for our students?
Oh, definitely. That's also another session that I attended. Like, it's being talked about, it is being recognized. And I know as far as our monthly faculty meetings, we have a DEI committee, so diversity, equity, inclusion, and we have some kind of presentation, and a lot of it's awareness. We have unconscious biases. I know there's people that have conscious biases, but a lot of it's just unconscious, and you don't know that you have that bias unless you've been told. I think we should be implementing there's unconscious bias like exams or little quizzes. So just bringing that to light. Each time we present a client in class, that's what I was talking about, that you need to keep bringing up client care. You can start trying to include more diversity in those patients. One idea that I have and I'm going to implement is diversity cards where you put on the back Jehovah's Witness or African American, Asian descent, different religions, ethnicities, and also LGBTQ patients. So, how would you care for this patient? We're talking about diabetes. Well, let's throw the card on the table. Well, they're transgender. What would change about their care? What questions would you need to ask? I think including it in your daily care, because it's going to pop up in your daily care, but having that included as a part of class can help them be more aware that they're going to have diverse patients in the real world.
We're put into a weird situation there because, back in October, our state legislature passed this law that actually bans public schools and universities from making that sort of thing mandatory. So, how do we get around that?
In our POI or our plan of instruction, it's included in our curriculum. So I guess somebody could say, no, I don't want to participate in talking about this case. And I guess we would have to respect that. But I think we still have to push for it, bringing the abnormal into the classroom and making the abnormal normal.
That's a tricky situation to be in with the whole sort of right wing push that we're getting from the government these days. I think it's very important to teach those concepts and make sure our students understand those concepts. I mean, you can get mad about it. You can say you can prohibit it, whatever. But at the end of the day, we're healthcare professionals and we're going to have to deal with whoever comes to us and whoever comes through the door. So, how are we supposed to just not talk about that?
I'm sorry, can you repeat that question?
I guess that was just a statement. Like, it just puts us in a bad situation.
I agree.
Yeah. It was SB 129. It went into effect, I think, in October of this year. I know UAH actually had a DEI office and closed it because of that. Here's the wording. It says it bars students, employees, and contractors from being required to attend any DEI training, orientation, or coursework that advocates or requires assent to a divisive concept. And there are 8 divisive concepts outlined, including conscious or subconscious racism, sexism, whether meritocracy or traits such as a hard work ethic are racist or sexist, and it empowers the state agencies to discipline or terminate anybody who knowingly violates the act. So we got to be careful there.
That's insane.
Yeah. That sounds like something that our administration needs to be worried about. But us too. I mean, I want to pass along the correct information, but I also don't want to go to jail.
Yeah, I agree.
There's this phenomenon in nursing where we put students through this whole education process. You go through nursing school and you pass your exam and you get your license and you get your job and you're on the unit and everybody knows you're a new grad and that you don't know what you're doing. What is the disconnect there? Why can somebody go through all of nursing education and still not know what they're doing when they get where they're going?
It's an issue for sure. I think it goes back to that application, all the things that nursing or nurses have to do. How do you replicate that as far as clinical experience? Because clinical experience, you go to the hospital, you're in a group with 7 other students, you're with your instructor. The instructor more than likely does not even work at that hospital nor that unit. We're guests there and we're only allowed to do what we're allowed to do as far as the instructor is going to give medications with this student and all of their energies put into safely giving medications with that student for that chunk of time. And so it's really hard to replicate what they're really going to be doing once they get out of school, which is if they're on a med surge floor, that could be up to 8 patients. And 8 patients come with 8 different primary problems with sometimes 20 sub problems. And so, yes, there's a problem, but I don't think it is our sole responsibility as nursing educators to fix that problem. I think we can do the students more justice as far as doing the active learning strategy and getting them to critically think and be able to apply these concepts. But our job is to get them to NCLEX, and NCLEX is can they be a minimally competent nurse? Minimally competent means they go in and they don't kill somebody that day. If you think about it that way, then it's a little scary. I think the hospital, and I know the hospital is not the only place that a nurse might work, but the hiring agency should have a better residency program instead of you're going to have 2 weeks of orientation and then you're going to be led on your own. That's not safe.
Sure.
Doing a residency program would ensure that they're meeting what they need to do to be set loose on their own.
I love the idea of residency and internship programs. That was very much my experience as a practitioner. Like you said, going through the clinical hours, it's not the same as you being out on your own. So I kind of felt like my first 2 or 3 years in practice as a practitioner were like my residency. And I would not have wanted to do that without a physician right across the hall. So I'm not a proponent of independent practice for nurse practitioners just based on my own experience, at least not right out of the gate. And I think the same is true for RNs, LPNs, et cetera.
And I think going back to our responsibility, we have to also prepare them emotionally and mentally for that and tell them the realities of nursing. But I don't think it solely falls on us.
And you can understand why a facility would be not super willing to let nursing students loose and do whatever they want and manage patients independently. Like, obviously, that's a huge liability risk for them. And I guess they don't have to host our students at all.
Technically, I guess they don't. We enter into clinical contracts, but it's also, hey, if you want our nursing students to want to work for you, then we are providing you with future nurses for your staffing problem. So please let us into your units and let them have a good experience. Otherwise, it's just going to make your problem worse.
Sure, mutually beneficial.
Yeah. And I know the apprenticeship program is fairly new within the last couple of years. Alabama was the first state to introduce the apprenticeship program, and Calhoun was one of the first programs to do it nationally, meaning we have this clinical relationship with them, but this deeper relationship where they are hiring our students, not a very huge group. I think they are increasing their numbers each semester, but hiring students in their second semester and paying for their schooling, but also they're getting their clinical experience one on one with a mentor. And we have seen those students do so much better clinically and have really advanced clinical judgment compared to traditional students.
Awesome. I love that.
But that can't be given to every single student. It's goes back to the hospital has to provide that. So not every student can go through that apprenticeship program.
Sure. Do you think it would be valuable to have even more clinical hours for our students than what they already are required to do, as opposed to more classroom hours?
Yes and no. I think changing the quality versus quantity would be the difference.
Better clinical experience is not necessarily more clinical experience.
Yes.
What advice would you have for somebody who's looking to go into nursing education, either from bedside or just is looking to go straight into that?
They really have to have a love for students. I really do love my students, but they come with a lot of challenges and a lot of diversity, and it's not an easy job. I'm not in it for the money. I'm in it because I truly enjoy education, and I think you have to know that from the start because there are a lot of challenges navigating being a new instructor, teacher, but there are a lot of rewards.
I've seen for myself that teaching is not easy at all. I got into it just as a side gig thinking, well, maybe this is something I would like. Maybe I would eventually transition into this full time, but I don't think so. It's hard. And I don't know that I'm cut out for it.
It's a lot of work.
It is. It really is. And my hat's off to you. I admire all the work you do. And I think you're a fantastic instructor. And I appreciate all of your insight. I appreciate you taking your time to talk with me about this.
Of course. I appreciate your kind words and encouragement. Maybe I'm doing something right.
Come back anytime. If there's a particular subject you're passionate about, or, oh, you know what we should do? We should do a video of one of us going through the escape room clinical simulation and see how we do. That'd be fun.
Oh, yeah, that would be cool.
I'm not posting it if I don't get out.
If you can't get out, then maybe the students can't get out.
Thank you again to my guest, Alaina Peterson. What a fantastic conversation. You'll get to hear more from Alaina at some point. Of course, I asked her to regale me with some more stories, and she certainly didn't disappoint. So look forward to that one coming out as a critical incident episode in the near future. Special thanks to our Patreon supporters. I should point out that we've increased the Patreon sponsorship by 50%. That's called exaggerating with statistics. We went from 2 supporters to 3. That's very meaningful to me. I appreciate that so much. To everyone, thanks for listening, and I'll talk to you later. All right, that does it for this episode of Knowledgeable Provider. Very special thank you to our Patreon supporters. If you would like to help support the show for just $5 a month, please head over to patreon.com/knowledgeableprovider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, subscriptions, etc. really do help the show, so take a second and do those things to help me out. If you have a request for an episode topic or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and take care of your patients in that order.